you for joining us for our webinar on substance use disorder data sharing workgroup recommendations. My name is Chad McLeod, Manager of Product and Communication at HealthInfoNet. During today's session, our team will discuss recent convening and engagement efforts in the state aimed at establishing recommendations for facilitating the exchange of patient substance use disorder information. Before we get started, I want to start with a few introductory slides. First, today's session is the second webinar of the year that is part of our new Stay in the Know webinar series. Our next session is scheduled for February 26th, which is an educational training on HealthInfoNet's clinical portal notification system. To stay in the loop of all of our upcoming webinar events, you can visit our website's webinar events page to learn more and to register for those of interest. During today's session, you'll hear from both Nicole Yo-Fisher, who is a licensed clinical social worker and HealthInfoNet's clinical educator, as well as Katie Gray, who is HealthInfoNet's Director of Client Operations and Programs. If you have specific questions to either presenter following today's event, you can find their emails and telephone numbers here. By the end of today's session, we're hoping that you all leave with a better understanding of HealthInfoNet and the state's health information exchange, the background and purpose of the SUD data sharing workgroup, the resulting findings and recommendations from that workgroup, as well as our intended next steps towards facilitating the implementation of those recommendations. Lastly, some logistics for today's webinar. During the meeting, all attendees will be muted, so please enter any comments or questions in the Zoom chat window. At the end of today's session, we will address as many as we can. We'll also be launching a few polls throughout the session, so stay tuned for interactive and anonymous Q&A. After the meeting, attendees will receive an email with materials from today's session. If you have any questions that you wish not to pose in front of the group, you can also reach out to us at general@infonet.org. With that said, I'll now pass the presentation over to Nicole.
Hi everyone, welcome. I'm Nicole Yo-Fisher. I'm going to start off just giving a little bit of information about HealthInfoNet and our background. So HealthInfoNet operates as the Maine State HIE, or Health Information Exchange. HIEs are a system designed to facilitate access to and a retrieval of clinical information to create better, easier, and safer care management and care coordination. HealthInfoNet is an independent, nonprofit organization which is governed by voluntary, community-based board of directors and advisory committees. Our members are represented by multiple stakeholders, which include medical providers, public health organizations, patients, government agencies, and businesses throughout the state. HealthInfoNet provides a number of services to our participating provider organizations, which includes not only access to our clinical portal, but within the clinical portal we have real-time event notifications, we do public health reporting, we have a predictive analytics tool, and more. So this slide is just showing you sort of the trajectory of HealthInfoNet's history starting in 2004 and bringing you to present day, which is the creation of a subsidiary company called Curious Innovations. So overall, the Health Information Exchange is connected to 790 plus provider locations throughout the state. The type of providers that are connected to us here at HealthInfoNet include all of the hospitals in the state, the acute care hospitals, critical access hospitals, ambulatory facilities. We have community behavioral health facilities that are connected with us, FQHCs, or federally qualified healthcare centers, post-acute care facilities, the VA, laboratory, health systems, EMS, emergency medical services, pharmacies, payers, and others. The data sources for the HIE, the clinical portal, include the following: demographics, encounters, vital signs, laboratory results, radiology reports. We have allergies, medications, diagnoses, conditions, problems, immunizations, and various clinical documents available. So next we're going to go into the background of our SUD data sharing project that we have been working on. that includes the state and federal guidelines for sharing substance use data. So we're going to start with a little bit of history. Obviously, the state of Maine, just like other states throughout the country, is currently experiencing the opioid epidemic, which does include more than one person each day dying from a drug overdose. Currently, there is a legislative task force that cited a need for the federal government to amend 42 CFR Part 2 and other related federal statutes to allow greater information sharing in regards to substance use data. Governor Mills had an executive order that outlines the initial actions that need to be taken, which included an appointment of the Director of Opioid Response, particularly through the use of technology and data to help prevent overdose deaths and increase treatment and recovery efforts, and also to bolster preventative strategies. So currently, there's a poll that you're going to see up here. Do you think that substance use disorder data sharing will improve patient safety? So we'll take a few seconds, I should say, to answer the poll question. Okay, great. So about 92% of folks say that it will improve patient safety, which is excellent. Okay, so moving on to our current Maine sensitive data sharing laws. So this is the current state right now at HealthInfoNet, which includes the fact that we are currently sharing mental health information in the clinical portal. So what we have is, at HealthInfoNet here, we maintain an opt-in mechanism for patients to choose to share their mental health information with the HIE. It does enforce protections on viewing the information that is requiring the HIE participant providers to unlock the data. So folks that are currently users will know this, that you do actually have to either go in and receive verbal permission from a patient. It can also be accessed in case of an emergency, or patients can sign an opt-in form that gets processed here at HealthInfoNet and makes that data sharing available to any provider that's logging into the clinical portal. So there is a Maine state law that requires that HealthInfoNet and HIE participating providers follow this consent policy. And patients also at any point can, if they choose to opt in their mental health data, they can decide at any point to revoke that, and they can opt back in as well at any time. So that process is sort of free-flowing depending upon the patient's choice and whether or not they want to share that data. We're taking a quick pause as we're trying to get to the next slide. Here we go. So the Maine HIE consent process. So at this time, it is HealthInfoNet's responsibility to manage those consent options, not the participating organizations. The consent relationship is between the individual, so the patient, and HealthInfoNet. What is required of our participating providers right now is to educate the patients on their consent options at least once during their interactions, and subsequently patients can change their choices, like I said, at any time. Consent choices are universal, so patients cannot particularly pick a provider, a specific provider, to access the data. So certainly if patients who do not want to globally share their information throughout the participating providers, that is a point in which a verbal could certainly come into play, where a patient can allow a provider to access that data through verbal permission. So the federal sensitive data data sharing laws currently. So per SAMHSA, the final rule in February 2008, 42 CFR Part 2 regulations patients may now consent to disclose their data, Part 2 data, to an intermediary organization, for example, in an HIE. Patients may now include a general designation, so a to whom, and a description of the Part 2 data they wish to disclose, an example, amount in kind. So to whom allows a patient to disclose all of their Part 2 data to an HIE and all of its treating providers, or they do not wish to disclose any of their information. An amount in kind allows a patient to disclose either all or a subset of their Part 2 data. HIEs may then disclose consented information to patients' treating providers. The consent form must include a reasonable time frame for data sharing consent expiration, and there must also include emergency access disclosure workflows outside of the consent process, so that in case of an emergency, a provider could access the information. So moving on, we're going to talk about the methodology and process that we used for our data sharing project, which included community stakeholder convening and engagement. So the project was funded by Maine Health Access Foundation and the Betterment Fund. What we did here was identify community stakeholders, which included healthcare providers, state officials, community peer advocates, and the recovery community. I'm not going to go through the whole list here, but you'll see we had obviously a fair amount of representation from all over the state. So the participating providers participated in a 12-month convening and engagement process, which was led by us here at HealthInfoNet and facilitated by a third-party expert. It included regional forums, small group workshops, and one-on-one feedback sessions. The project objectives were to establish a shared understanding of the crisis and how it's having an impact on surrounding communities, to assess the current and future state potential for sharing protected clinical data pertaining to substance use disorders, and also develop recommendations that could lead the state forward with implementing data-informed workflows. So we had discussions, deliberated shared findings and opinions. We created work groups to discuss those recommendations. We organized proposed recommendations into 4 aspects of the data sharing, which included discussions around the legal framework, how to incorporate this into patient consent materials, then how could it be established within the current treatment workflows, and then also discussions around how this would work from a technical perspective. And I'm going to pass it on to Katie Gray, our Director of Client Operations and Projects.
Wonderful. Thank you so much, Nicole. Good afternoon, everyone. My goal is to wrap up our presentation today, and then we'll get into a couple more polling and Q&A sessions to wrap things up, to really talk about our findings and recommendations of the project. And before I even get started on that, what I'll say is that we have initial findings and recommendations because this work really is an evolution and is going to come in phases. Whenever we do anything new related to patient consent, new data workflows, et cetera, we always have a starting point that we all agree to as our initial phase, and then we evolve from there as we learn and gain real-world feedback from the clinicians and the users across the state. So for the folks on the call that are our users and participants, we'll be working with you continuously at a leadership and at a user level to learn from you and gain feedback. So this will not be the first time we'll be having this conversation. So some project themes and findings just to get us started here. We had really successful collaboration among our participants, and we really just go out of our way to thank everyone who did participate and volunteered their time to do that. That continued effort of collaboration across the state has allowed all of us to be successful in evolving and being innovative. Our data sharing practices really do support advanced treatment and innovation around our community efforts to help improve patient outcomes related to folks that have substance use disorder. And what we're really trying to do is integrate our recommendations into existing workflows, because we all recognize that the administrative burdens and ongoing complexity of consent and informed consent is a real challenge, especially in the SUD treatment workflows that we learned about throughout our convening process. And our third point here is that, this cannot be said enough, is that we had a lot of work to do to really learn initially and then get caught up from a HealthInfoNet perspective, but then as a project perspective around what is going on in the peer and recovery communities across the state of Maine. And that has been a big movement, not just within this project, but across the state as the state works under the governor's direction to expand peer and recovery communities, roles, et cetera, within the treating community, but also in the non-treating community. So that was a huge project theme and finding throughout the work that we've done. Okay, so we're launching another poll here, and we appreciate you guys participating. Do your patients with substance use disorders experience bias and discrimination in their healthcare treatment and/or recovery interactions? Okay, I think we are done with that poll, and thank you all very much. I think what we wanted to do today with all of our polling questions is to really follow up on some of the themes and findings that we heard throughout our collaboration process in the project, and I think it's going to help us as we move forward with our final recommendations from this initial project and then ongoing, go back to the input that we get from our stakeholders. So this is just another example of your input and collaboration, so thank you so much. I next want to talk about our legal framework recommendation set. This is complicated stuff. Everything we're doing here really has to be rooted in federal and state law review. SAMHSA is really the source of truth that we all look to in the community to help guide our work around this effort. And so that is what this project was first and foremost rooted in, and the stakeholders ensured that was continuous throughout the process. So from a legal framework, what's really critical is that we incorporated Part 2 rules that Nicole reviewed and introduced at the beginning of the webinar into the different aspects of HealthInfoNet. So whether it's our consent form process or our legal agreements, we have to consider all of this as the foundation of the effort that we're going to implement in an ongoing way. So our goal has been to incorporate what is really a summary here. So nothing you see on this slide here is necessarily verbatim from law. It's really our way to analyze law, interpret it, and boil it down in a way that's really digestible to the community and also applies to health information exchange specifically. So I know that there are often questions that our participants and our community partners nationally that we're partnering with on this effort around how we are interpreting law or how we do view a particular component of law, and really those are ongoing conversations and learning opportunities because no one has really achieved this in a universal way nationally. We are collaborating with some other states and will continue to do that work. Those other states are waiting eagerly for our recommendations report, which we'll talk about in terms of next steps at the end of this webinar, but I just can't say enough about how much work there still is to do on the legal side of this nationally. So we're starting someplace, and we'll continue to learn work with SAMHSA, learn from SAMHSA, and move forward. In our recommendations that patients may choose to disclose all of their Part 2 data to HealthInfoNet in the HIE, and therefore all of its treating provider participants, or not to disclose any of their information. I won't necessarily get into this, but please remember that Nicole did talk about emergency exception workflows as well as verbal consent workflows. So when we're stating here that patients have a choice in the context of the consent form, we're talking about written consent workflows that are universal. And when we move forward with our participants on training, with communication efforts, et cetera, all of these different delineations around workflows for the users and the staff responsible will be very clearly delineated. Patients may choose to disclose either all or a subset of information. And we also must comply with a requirement for what we refer to as an expiration timeline. In our proposal is 1 year following the date of a patient's signature on the consent form, and that will be considered a reasonable time frame for SUD data sharing consent. So for SUD data specifically, you would have to have a workflow where a patient would have the opportunity to renew that consent annually, unless they otherwise revoked that consent prior to a year, et cetera. Okay, getting into the patient consent materials recommendation. Currently today, for folks that may be unaware, we have a sensitive data consent form that we refer to commonly in our community as the opt-in form, and that relates to Maine state law and our requirements that Maine state law has specifies above and beyond any federal laws in this area around how HealthInfoNet as a statewide designated health information exchange should manage sensitive data, and that today pertains to mental health and HIV. So Nicole talked a little bit about that in the beginning. So to really facilitate an easy workflow and make this palatable as we move forward, what we're recommending in partnership with our stakeholders is revising the HealthInfoNet sensitive consent form in the following way. So we're maintaining a single comprehensive form for all sensitive data sharing options. We're including granularity related to the substance use data sharing options to comply with the recommendations of our framework that are based out of SAMHSA in the final rule, and we'll be defining that 1 year time frame for specifically and only to the SUD choices that the patient has available on the form. We are not adding a 1 year or recommending adding a 1 year time frame to the other components of the consent form. Clinical treatment workflow recommendations. We talked a little bit about how there is quite a bit of complexity from state regulations and federal regulations around informed consent for folks who are entering into substance use disorder treatment programs, organizations, et cetera. And so really what all of our stakeholders need in order to comply with their requirement to provide comprehensive education is they need strong support from HealthInfoNet. This is nothing new. HealthInfoNet has been providing education. Nicole is currently the lead on this with all of our participants. We provide initial and ongoing education and training to leadership and then ultimately frontline staff who are responsible for the Maine state law requirements for consent education. HealthInfoNet maintains a communications package. We work hard to make sure all of these materials are up to date and available on our website so that whether we're talking about consent forms or training staff, we have everything that we need to support you all as our participants in having standardized best practice approaches to workflows. So this foundation knows everything we do here carried over into this project, of course, to have this conversation. So our goal will be to have a robust communications and education toolkit to support providers around education specifically for substance use staff, and really that has to go hand in hand with compliance and clinical operations leadership. All of this effort and all of these recommendations have to include legal and compliance leadership and operational leadership, because it will require ultimately those workflow changes. Having the revision, the new consent form available and educating on that will be incorporated within existing provider workflows, and primarily what we've talked about within our recommendations and will be in much more detail in the report is that this will be aligned with both intake appointment processes from more of an ambulatory perspective, and then on an inpatient perspective, it would be recommended to be coordinated with discharge workflows. I say that because there was a lot of conversation throughout the process around what's appropriate timing for having truly informed consent conversations with patients about HealthInfoNet consent. From an ambulatory perspective and entering into treatment, the majority of the time that felt like to our treating provider stakeholders was appropriate to incorporate within that process so it doesn't get missed and it's consistently addressed, and if there is an annual renewal, it gets addressed as well, so it's not forgotten about later. From a discharge perspective, or if someone comes in through an emergency or a crisis workflow, that is clearly not the time to have this kind of a conversation, as well as the healthcare providers also know that is not the time when they're doing their informed consent as well. So we've talked about having discharge and handoff workflows for those different types of acute situations. Technical operations. This is where things start to get really complex, and if depending on what your set of expertise are, can start to go over people's heads, including my own at times. We've tried to keep our technical operations recommendations really more at an operational level and less at a technical development level in the scope of this project. We have had ongoing conversations at HealthInfoNet around how to operationalize these recommendations, but from a community perspective, the engagement process around the technology was kept at a high level because that's really what has been appropriate in this initial phase of convening. Our goals here are to leverage our existing technical infrastructure, not only at HealthInfoNet, but with our partners. All of our data sharing partners today and in the future maintain complex interfaces and data sharing environments, and there's a lot of compliance and security and workflow that those folks are responsible for. And so, you know, no one has more money in their budgets to add additional burden in these structures, so in order to be sustainable and ongoing, we need to maintain the infrastructures that we have wherever possible. So what we're focused on doing at a high level is bulleted out here. We're focused on transitioning from a model of sensitive data blocking to a model of flagging sensitive data. And I say that because the word blocking is used very commonly in the HIE industry and nationally. We hear a lot in the news about data blocking rules changing, and everybody is keeping a very close eye on what that means. And I know that there's even more legislative activity happening even now that relates to 42 CFR Part 2, although it is nowhere near impacting any final rules. This will continue to happen. We will continue to see federal changes around goals to remove data blocking across the industry of healthcare. So today, providers and the technical staff have enormous challenges and spend a lot of time testing and validating and monitoring sensitive data blocking from their data environment, from the electronic health record systems. That's just the key example. A large part of that is flagging and identifying that data so that it can be segmented properly. What we're hoping to do is overall simplify some of that manual work into a more automated process so that all data can flow from the healthcare providers' systems through their interfaces to HealthInfoNet, and through a flagging process, allow HealthInfoNet to manage that sensitive data appropriately according to the consent choice of a patient at a point in time. That allows HealthInfoNet to really receive openly all information and then maintain that information according to the consent choice and also the emergency requirements that Maine state law requires for mental health data and federal sample law requires for Part 2 data. So today, this does build off of our current workflow for data sharing for sensitive data. So today, if an organization is sharing mental health information, all of that mental health information is flagged as such. It comes to HealthInfoNet. We store and manage its access based on the patient's consent. Either they've globally consented and opted in, or they have the option within the portal to go through a audit consent process that allows them to access that data one time via the verbal consent workflow, and Nicole talked about that. And then there's also the emergency requirement. In order to comply with verbal emergency access, you have to have the data to begin with. And so when we initially designed our sensitive data model back in 2013 and started receiving the mental health information in 2015 from our participants, and we've continued to do that since then, this was a big piece of that initial work. And so now that we have this precedence and we have experience with this with our community-based mental health agencies, and we've learned a lot about this technical process, we're able to build off of that and improve on it and leverage it so that we can add additional sensitive data sets. And we feel really good about that because we have a lot of experience with it, and our providers now have enough experience with it that we've had enough time pass since 2015 to learn, perfect that, gain feedback, understand where there's gaps and flaws. So it feels like a very timely process now to iterate and build off of that for the incorporation of the substance use data work. I know there's going to be questions about this over time, especially for a lot of our participants. There's no technical folks on this conversation, and I'm sure everyone is wondering about how to have these conversations with your folks. When I talk about next steps in just a couple minutes, I'll say a few words about that, but just know that we have recommendations and we are not ever going to move swiftly to technical operations. So we're not there yet, so I don't want anyone to feel too worried about that we're just all of a sudden jumping into the technology. Our goal here with this project was to start the conversation because we still have more work to do on the legal and contract side before we get here. So to wrap this up in terms of our project and our convening conclusions and next steps, I want to just say a few words about the project overall, and then I'll end with what are more of the concrete next steps with our participants in Maine. Overall, I think we all would agree that there was really positive and broad stakeholder and community support. We met with a lot of stakeholders that chose not to formally be a stakeholder involved in the project because it just wasn't directly related particularly to their organization or their day-to-day work, but they appreciated knowing about it and wanting to be involved and supported us, and then also made recommendations about who really were some of the thought leaders in the state around how we can use technology and healthcare innovation to facilitate better outcomes. And so we just feel really positive and appreciative overall around the project. And again, thank people enormously for that. There is so much co-occurring disorder and overlap between what are traditional chronic conditions and physical illnesses and mental health conditions and substance use conditions that I think everyone has been kind of groomed to start to learn this and understand the intersection of all of this work and why this is also important and why this data needs to come together. And our partnership with the state, and in particular Medicaid, behavioral health homes, opioid health homes, the different models of care, changing the care team structure, all of that really is the work that's going on in parallel to support that broad community support. So kudos to everybody who's working on it in your own world. Point number 2 here, we all are still cognizant and recognizing the fact that there still is bias and discrimination in clinical settings for patients receiving SUD treatment and or in the process of receiving recovery and treatment services. And this is a significant issue that is going to overlap and interweave with our ability to advance technology and innovation. We all acknowledged throughout the project that bias and discrimination is real, it's an issue, it's something we have to acknowledge and work through together and learn together and not shy away from it. And I think that that is what is happening across the state with the stakeholders' input that we've received. So HealthInfoNet acknowledges this and is sensitive to this and will continue to participate in efforts around this culture change. So we want to make that super clear. And we really want to thank and appreciate our peer and recovery members who gave their very sparse time and took time away from intervening in crisis and in patient care to participate in our project. With that said, we have a report that's going to be coming out. I think it's about 11 pages right now, but our report is a very detailed background and summary of our findings and recommendations in a detailed level that builds off of what you've heard here today. We will be sharing that with our stakeholder community and making that publicly available. And in particular, our state partners that we're partnering with in Maryland, Washington, D.C., Arizona, Colorado, and elsewhere are eagerly awaiting that report to help support and inform their collaborative efforts that they're currently doing in other states around this topic. No one has really gone first yet to implement some of the recommendations that we've made here, and so we may be, again, one of the thought leaders nationally, as we've been in other areas with mental health. We are still one of the only states in the country that share and integrate mental health information with physical health information, and so we're used to being first. So this is really a continuation of that, and we're looking forward to our peers' feedback as they have a similar conversation in their states. Lastly, I guess what I'll wrap up and say is that our current participants all operate consent and sensitive data rules under what we call our participant agreement and our business associate agreement. The next steps with our participants are to work through our current draft amendment to that participant agreement that incorporates SAMHSA final rules requirements and allows us to move forward on a contractual basis with the framework and recommendations we put forward with here today. As a part of that process, I am sure there will be edits and changes along the way to how that amendment works, how the consent form processes will ultimately be finalized in their initial phase, and then we will, from there, work with our clinical leaders, our consent leaders, and our technical leaders around the project implementation for those components of the work. So please know, if you are a participant on the call, that you will be engaged with and will be talking with you in the next quarter of months coming up here around the legal work and then moving forward with technology and operations. Some folks have already had these conversations because they've been participating in the project. For those that haven't, it's coming your way next, and we look forward to working with you on that. Okay, we have one final poll for everybody this afternoon. Do you think that the separation of primary care data from substance use disorder data, i.e. creation of data silos, contributes to bias and discrimination of patients with SUD in their healthcare interactions? The reason we're asking this question is because this came up a lot. There's lots of different ways bias and discrimination have been taking shape over the years, and some folks brought this up as a concern that having data silos further creates and I guess encourages bias and discrimination. So we're just curious what folks think about this today. We'll give everyone a few more seconds to respond, and then we'll wrap up with some Q&A. Okay, thanks everybody. Appreciate it. It's very interesting.
All right, great. So this is Chad again at HealthInfoNet. I'll tee up some of the questions that we received both in the group chat and as direct messages. So to start in the order that we received them. So additionally, if there are any other questions that folks on the call have, feel free to add them to the group chat as we go through the first few. So the first one, and Nicole and Katie, feel free to triage as you wish, but the first one is, why isn't there a separate form for SUD consent? So why is it combined with the mental health and HIV form?
I think ultimately we chose to do that to make it easier on everybody. We know when we sat in with obviously some of our community providers who go through an intake process with a new patient, and I'm sure as most of you on the phone who are doing that sort of direct care work and go through the intake process with patients, there's a lot of forms that need to be completed, and oftentimes those forms can take the whole first appointment. They could possibly go into a next appointment. And so really we wanted to make it easier for the patients. We wanted to make it easier for the providers who are going through consent options with folks, just to lay it all out on one form. So that way it's not confusing. They're able to go through patients' questions pretty smoothly in one form and ultimately just save time and paper. That it's all just combined into one document.
Great. The next question is, for an organization that does not provide SUD treatment but has clients that do have SUD, is that organization still the connection point between patients and HealthInfoNet regarding the consent for substance use disorder information?
Great. Thanks for the question, Sue. Hi. Nice to see you on the call. So this is Katie, and I'll just take a stab at saying that I think our goal, once we've really gotten through universal updates through our agreements and education is in place, I think ultimately it does make sense for every agency, participant, organization to have all of the consent forms available. Because as Nicole was saying, when she's doing the education and we're spreading all this information, really the patient can receive this information and they can opt in and or out really anywhere at any providing care location, as well as through a website or a phone call to HealthInfoNet. So there's many ways we try to make these options available. Of course, just because a patient might provide you with an opt-in form if you're not providing SUD, but they want to release SUD information to HealthInfoNet or disclose it to HealthInfoNet, it doesn't mean you are sending us that information because you don't have it, but just making it available. So thanks, Sue, for your response back.
All right. The next question is how does HealthInfoNet distinguish between substance use disorder data and mental health data in the exchange of information with the HIE?
This is Katie again. I'll take a stab at that. This really comes down to the participants' determination and delineation of which licensed providers, which licensed programs are subject to Part 2 rule. So we all know that interpretation of Part 2 rule varies, and there's some gray areas. And so our participants will still have the fun job of determining their own compliance with Part 2 and where it applies and where it does not apply. We all know that this is tricky when it comes to primary care, medication-assisted treatment programs, et cetera, et cetera. So it's not simple, but ultimately this decision sits with the participant, and then that data flagging process has to comply with the participant's policy and compliance.
All right, great. And I think this next one would be for Nicole, so I'll start there. So if the patient account is locked for our providers to look at, who shall we contact to unlock it? And does the patient have a sign-off or a release of consent form for it? And if so, where can we find it?
Yes, so great question, and that's sort of like an overall consent question. So ultimately, if you go to search for a patient and you're not able to click on that patient, or you'll actually see what looks like an actual padlock, that means that that patient has opted out, and there actually should be an opt-out date under the opt-out column when you go to look up a patient in our patient demographic search. And so when that occurs, ultimately what a patient has to do is complete an opt-out revoke. So obviously at some point, this patient had decided that they did not want to share their general medical information into the clinical portal, and so they do need to complete that revoke form, which is available on our website to be able to access and print off. Patients can obviously too, they can call us here at HealthInfoNet and let us know that they do want to opt back in, so that is also an option. But certainly that form does need to be completed, then it would be processed here at HealthInfoNet, and then the information would be available for folks to see. So great question.
Great. Thank you, Katie and Nicole, and for everybody that attended. That looks like we've answered all of the questions in the group chat. We'll stick around for the next few minutes. If others have lingering questions to ask, feel free to add them to the comments section. A reminder that our next webinar session, if you're a clinical portal user, is on February 26th, at which point we'll talk about our notification services. So thank you again for attending today's session. We'll follow up with an email to provide you the materials from today's webinar. And again, we'll stay on the line for a few more minutes if folks have questions. So thank you.